some people are, maybe they've already listened to the audio of all of this and want to go back over it in that way. And I'm not gonna be insulted about that or whatever. So that, but because I did that. So for you all, if you, whatever method would be better for you is to study the audio thing or to come to class. So at least you get some options. Okay, so I'm going to go to share screen. Hopefully I will get it in my pulmonary effects. And I'm going to cut this down. Hi, Michaela. I don't know if you can hear me yet, but anyway. Okay, so I get my slideshow. And from current slide. All right, here's our pulmonary effects. So here's our oxygen, O2, O2, O2. This is, it can be pulmonary effects from radiation therapy and for some kinds of chemotherapy. So with pulmonary effects, y'all have had your respiratory unit, and a lot of pulmonary problems that you treat the same way. And so here we go with bronchodilators and expectorants or cough suppressants, or just rest, because if you're really fatigued, if you're not doing a lot of oxygen exchange in your lungs, so you're going to be tired, and some supplemental oxygen is one of the things. So what you could see is fibrosis on a chest X-ray. If you look in your computer at clinical and look for the X-rays, it can say the fibrosis in the lungs, and so that can be or the chemotherapy or radiation therapy can be the cause of that. And if it's in an acute phase, you may use steroids like you would use in COPD to decrease the inflammation. Well, they use steroids with COVID, because COVID attacks the respiratory tract in a lot of people. And then you would taper them down like you would with COPD treatments. And so the nursing diagnosis would be impaired gas exchange if the ABG is available, and if the pH is abnormal, and if you've got a lot of problems with
Miss Beaver?
Yes,
Please, can you record for me, please?
What's that?
Can you record for me, please?
Oh gosh, I forget it every single time, Bear. I'm sorry, you are my memory. I tell you what. So I'll tell you, we're all so anxious here. Let me get this stop share thing. Gosh, it's up at the top sometimes, and it's up down at the bottom sometimes. There we go. Let me see. Do y'all see the little red button now?
I see it.
It is on now, right? Okay, good. All right, so let me go back. Thank you, Bear. You are my salvation with remembering to do this, because we've been told not to do it at one time, and we skipped it for a few times, but now we can do it now. So, okay, let me get my. Gosh, why is that not? You have to hover and get the share screen. All right, here we are again. So we'll do our bronchodilators, our expectorants, our cough suppressants, bed rest and oxygen, and you could note the fibrosis, because when you got fibrosis, it is fibrous. It's not elastic anymore. It's not going to be it's not going to be flexible for those alveoli to be able to exchange the oxygen and the CO2 in between breaths and such. So it does mess with the flexibility, and it can be, some of it can be permanent, and but the patient may end up having to be treated like a COPD patient because of the permanent damage if you took too much radiation, or if you'd had a reaction to the radiation. Sometimes it just gets so much inflammation in there that the inflammation damages the lungs. And so then let's see, what else was I going to say about that? So we were talking about inflammation and the steroids that you may have to take steroids, and people that did have problems with their chemotherapy. There's one medication that we don't use a whole lot, but it's bleomycin, and even that cyclophosphamide, which is an alkylating agent, we'll talk about, but it can damage your lungs, because it just reminded me about this guy that was 24 years old, and he had a type of leukemia, and that it was a chronic leukemia, and the only way that you could cure it back then, it was, gosh, that was like almost 40 years ago now, but bone marrow transplants were really new and sort of experimental, but this fellow wanted to have that done, and he did end up having total body irradiation. That's what they would do back then to help wipe out all of the blood cells in the bone marrow, and then you rescue the patient by putting it was actually his brother's bone marrow into it. You transfuse it into the body, and so that guy was doing fine. He was his blood cells were coming back and coming back and coming back, but he had taken that cyclophosphamide also to help kill all of those blood cells too, or to kill the bone marrow, so that you, when you got the transplant, it would go, those particular transplant cells would go into the bone marrow and start dividing and start making blood cells. And so what happened though was he did have a reaction to the cyclophosphamide, because it was a really, really high dose of it. And that, along with that total body irradiation, caused this fibrosis and inflammatory fibrosis thing, and he died. And it was right before I got married. And at first, just getting all the stuff together with getting married and everything. And on our honeymoon, we went to Acapulco on our honeymoon, and sitting by the pool, and I just started just bawling, just crying and crying and crying. And my husband was like, "What is the matter? You don't want to be married to me?" Whatever. But I was like, no, it just hit me that he died, and he had been in the hospital a lot, and we just got to know him really well. All of the nurses did. And so it was such a sad thing. And so it can help. It really was, I guess, the two things together, the cyclophosphamide and the total body irradiation, caused those pulmonary effects. Okay, so gastrointestinal effects. We're going to do, prophylactic means preventive. Administration of antiemetics, and I guess y'all already know that term. Emesis is vomiting, so we want it to be anti-vomiting medicine. So we're assessing for signs and symptoms of alkalosis and dehydration, and that's one of your fluid and electrolyte maybe questions, huh? So when you're dehydrated, and you're going to have some alkalosis. So INO, and then our non-irritating diet and antidiarrheal medicines. This is very, very general, but anyway, that's a kind of like it in a nutshell. So the prevention of nausea and vomiting with those antiemetics, it works best to avoid anticipatory symptoms with later treatments. So I may have already said this before. I think I did, but about that man that was in the grocery store, and just anticipatory. He had vomiting, nausea and vomiting, because he had emetogenic chemotherapy that really made him sick. And so we didn't have as good of medicines. We didn't have Zofran, and we're on Dancitron, I'm supposed to call it, but we didn't have that then. And the other things didn't work too well for him. And so he I saw him in the grocery store. I was talking to his wife, and I waved at him from far away, and he was down another aisle, but he saw me. As soon as he saw me, he walked across the store, and then he went. His wife told me that he went outside of the store and threw up. So anyway, it is anticipatory because it is very real. It's physiological. Your brain, your nausea and vomiting centers get that message that, okay, now you see that nurse that gives that nasty stuff that makes me vomit. So I see that nurse and then I vomit, and it's like, okay, that sounds really, really terrible. Well, it is terrible. It's really, really tough, and it's not like it's just in your head. Well, yeah, your head and your brain, and they're all physiological parts of your body, but it is very common. Anticipatory. We talked about anticipatory grief, and then you talk about anticipatory emesis as well, or nausea. So that's one of the big deals for us to work with. So and we want to do it. We want to give the patient their medication if we know that it's really highly emetogenic in that particular medication. We do want to give something like ondansetron and some maybe combinations of antiemetics as well, not just the ondansetron, but that one's like the most powerful. But you don't want to wait until the person gets sick. You want to prevent it, because if the patient has gotten sick already, then they're going to remember it, and that anticipatory nausea can really be a problem. Sometimes it can cause weight loss and alkalosis and all that kind of stuff. So we want to be preventive. We want to give that medication about 30 minutes to an hour of. We used to do it always in IV form, but you can use it orally. But we usually didn't do it orally, have them do it orally, because there may have been some kind of an issue. They would see the doctor first, and then the doctor would say, well, okay, you've got a rash. You're not going to take it today because we need to look into that rash. And then the patient would have already taken the medication. And so we would always do it in IV form. So it sort of depends on the way the doctor works with that. Okay, and that's just sort of a nutshell here. And here's our reproductive effects. And at first I just had this one for the young people. It's about, how they would they be infertile, what's going to happen if they want to have kids. And but I started thinking, you know what, these older people, they like to have some sexual intimacy too. Some of them do, some of them don't, but it's really getting more and more common. And so it does really upset even older people, because it's like, oh well, I'm old, so I just won't worry about that. Well, it can be a really hurtful kind of a thing when you lose your capacity to have sexual satisfaction, if that's something important to them. So that's why I put that on here. So we do want to inform patients about sexual side effects or potential sexual side effects, because there are some medications that cause some nerve damage, and it can cause some impotence, and it can cause problems just with your sexual satisfaction, or just not having sexual satisfaction, or whatever. So it can change things, and that's a real important thing for a lot of people. So referring to counseling if needed. And the Lance Armstrong, it was a Lance Armstrong website that it's called Livestrong now. It was merged with another website that was called oh gosh, now I can't think of the one that it was called at this point, because that's been a long time ago. But anyway, it was one that was about sperm and egg banking and things like that. So they if you go to livestrong.org, it is on that sheet that or on Blackboard where it has those websites, and it's livestrong.org. And if you do the search button, do the little magnifying glass and do the fertility options, just put in fertility options, and it will give you some information, or it will give you links to where you can get the information, because I just looked at that a few weeks ago. So anyway, that's it. We do need to deal with sexuality, because it is important to a lot of people, and we don't want to ignore that. And if we do know that, like if the nurse is going to be having the explanatory, well, I guess it's like after the doctor explains things sort of in general, and then the nurse comes in and explains things for informed consent to take those medications or take the radiation, then you sometimes that can be embarrassing to well, especially some young people are embarrassed to talk to an older person about something like that. But kind of the older you get a little more used to saying things like that. So if you really do feel that you can't handle some of the details, if they're asking you really difficult questions that you're uncomfortable with, have somebody that hopefully there'll be somebody that you work with that can actually come in and explain some of the things if you don't feel comfortable doing that or going into more detail. Some people may just say, just don't talk about that. I don't want to talk about that. Okay, you go with them if that's what they want. But if they really want a lot more information, then we do need to provide that for them, or have somebody that will provide it, or maybe even just a website or some videos or something like that. So anyway, we don't want to forget this part, because it really is important to people's their mood and their just satisfaction with life, and their just intimacy with their partners and things like that. Okay. So this is really something that you do. You're not going to be tested on this. I just want you to know about this, because you've already probably, if you've listened to some of the news stuff about COVID, and all these medications that they're trying out and everything, and so it's the people from the CDC and all are looking or trying to explain how you go through a process to approve a medication for the FDA. And so I'm just going to go through this pretty fast, but the phase 1 is a small group of people that are tested to evaluate the safety and determine the dosage, like how much of it will be toxic. If it's starting to get toxic, then you stop. You won't give any more than that. And then you identify the side effects from it. Every now and then there's like people that they're really in pretty good shape as far as being able to take care of themselves, do their ADLs and stuff like that. And so they are the ones that volunteer for some of those phase 1 trials, because they don't have anything to lose, because they have they've used up all of the other options that are standardized options that are approved by the FDA. So they're okay. Let's just see. I'll just do this, and so I'll help humanity. Because I can't. There's nothing else I can take. Well, anyway, sometimes the phase 1 medications actually work. That's not what phase 1 is for, but sometimes they do work for certain people, and you can get permission from the FDA sometimes to get I think it's compassionate use. I think that's what they still call that. Well, anyway, so phase 2, you have a larger group to test the efficacy and then further evaluate the safety. And then the larger group is tested to confirm the efficacy and monitor the side effects and collect information on the safety of the drug or the treatment. And what you're actually doing is comparing it to the standard therapy that that can work, but that you're comparing the side effects and how well it works according to comparing it to medications that are already out there. So anyway, that really is just an FYI. But I just wanted you to know that that's how chemo drugs and are phased in and everything from the FDA, but it is for any drug going through. But sometimes they go through a faster process, which we're trying to do with the vaccine issues. So anyway, the eligibility criteria usually denote a certain level of functional status for cancer clients to participate in the study. And what I want you to know on this notes page is the ECOG scale. It's Eastern Cooperative Oncology Group scale, and the higher the number, the worse that is too. Again, the high numbers are bad, but anyway, this is this functional status. So when we've got 0, it's fully active, that you're able to carry on all your pre-disease activities without restriction. That's probably not very common, but if you have cancer, that's the deal. And that's how you have to look at this before you can put somebody on a clinical trial. So anyway, the number 1 is you're restricted in strenuous physical activity, but that you're ambulatory. You can carry on your work of a light or sedentary nature, like light housework or office work. So you still can function. You can maybe still be in your job. And then the number 2 is ambulatory and capable of all self-care, but unable to carry out work activities. So you're up and about more than 50% of the waking hours. And then you're capable of only limited self-care and confined to the bed or chair 50% or more of those waking hours. And then number 4 is completely disabled. You can't do really anything much for yourself, and you're totally confined to the bed or chair. You may be in a coma or, unconscious. And then number 5 would be not compatible with life. So that's when you are deceased. So go from the 0 to 5. 0 is perfect, and 5 is as imperfect as possible. So anyway, that really makes sense if you look at that. So don't just try to just memorize it. Look at it and see how much sense it makes. So you got 0 and 5, and like 1 and 4 you can compare, and then look at 2 and 3, 50% up and 50% down, more than 50% down. So if you look at that, it really will make sense with that, with those numbers. So I do want you to study that. All right, this is another one of these biggies, but you probably have already looked at some of the things on the under those practice problems at the very end when I was giving some other suggestions. I did that. Gosh, I don't remember exactly when I did it, but I went ahead and did that for some students that were really nervous about it. And so I just always tell y'all to look at this. But our goal is to reduce the number of cancer cells in the tumor site or sites. And there are several factors that determine the response of the cancer cells, and the cancer cells can escape death by staying in that GO phase, that cell cycle handout, or the one that you see the cell cycle picture in your book. And so that GO is a resting phase. And so if it's resting, it's not dividing, and the cells respond a lot more to the chemotherapy, or almost totally, for with the cell division process is not going on. So the ones that are dividing are more susceptible to the radiation and the chemotherapy to kill those cells. And there may be some cell cycle non-specific medications can get into the cells that are in the GO phase, but it's much more likely that they'll respond when they're dividing. So the main problem is the presence of drug-resistant resting and those cells that are non-cycling, not dividing. So systemic chemotherapy does reach the tumor itself as well as distant sites. So we talked about our surgical and our radiation are both of those are localized treatments. And then systemic chemotherapy, if it's oral or if it's IV, and that could be like in a pump to your liver. That's a localized treatment sometimes too, but it's not totally. You're not all it because it'll go through the rest of your body and with metabolism and everything. But it hits the local area first, and then it's not going to damage as many other cells if you've got one like a liver pump and you're trying to treat it like right in that one area. But systemic chemotherapy is going to go all over the body. Okay, so our three general purposes are to cure or increase survival, and we can palliate, which we can make people have a better quality of life, and then prophylaxis. You can actually prevent things. You can prevent problems. So then you may look at that if your Kaplan Basics book. And I did have concept book there. Y'all don't have the concept book. I should have got that out of there. But in a pharmacology book, if you've looked at all of that, you may see the like that my chemotherapy classification group handout. I think everybody probably just fainted when they saw all of that. I'm just going to give you examples that I want you to look at, just like well, it's our prototype drugs for some of those categories. So don't freak out about that. But Kaplan does have good charts and things about chemotherapy. So especially like if you have a patient with a certain medication that you have to look up, Kaplan can give you some perspective on that with the chemo charts or my chemotherapy classification group's handout. So anyway, on Blackboard, and when I said your resources, what you need to study, it can be in a pharmacology book, but you can here's some things I'd like for you to know about selective pharmacotherapies for cancer. So nitrogen mustard is an alkylating agent. It's called mechlorethamine, and it's a precursor of the cyclophosphamide, which is the brand name is Cytoxan. And nitrogen mustard is a vesicant. And look at the slide with the chemical burn from the vesicant extravasation, and there's a really terrible picture of that in your book too. And Cytoxan's an irritant. It's not a vesicant, but it can be irritating at the site of the IV. When you take it IV, there are some oral Cytoxan. Sometimes there some of the regimens use oral Cytoxan, but most of the time it is IV. So central lines are used more and more, and it's so much more safe to take the regimens that way. Especially with vesicants and then the irritants as well. And so you can look up those potential side effects of the Cytoxan. And then interferon is biologic therapy. Interferon is something that our body makes to fight viruses, and it can be used to let's see, I lost my place here. So it can be used to increase the body's immune response with injections of that same chemical, and it's made with recombinant DNA technology. And we used to have up in CRC on the third floor, just right across from the bathroom, they had one of those easel things, and it was talking about recombinant DNA technology, and that they teach that in that upstairs lab. Was somebody asking me something? Or maybe it was just not the mic. Okay. So let's see, the greatest side effect is flu-like symptoms. Because see, when you have interferon fighting a virus, it's really like if you get a fever and chills and you just feel terrible. Um, that's because that interferon and lots of other immune chemicals and cells are fighting too, but what makes you feel bad is the process of your body trying to fight the viruses, and that's why you feel terrible. So when you're taking interferon, which is biologic therapy, the greatest side effect is flu-like symptoms. So fever, chills, malaise, just fatigue, just horrible feeling. So, so know the nursing care suggestions from the interferon slide. That'll come later. Okay, so our tamoxifen is a hormonal agent, and it does change the intracellular and possibly extracellular environment to suppress the cancer cell division and allow for tumor regression. And it is an anti-estrogen, and it is for estrogen-dependent breast cancer treatments. And so it does block estrogen receptors. So I want you to know how that works. It blocks estrogen receptors on the tumor cells so that that estrogen can't be available to those abnormal cells so that they can just fizzle, or they may not die, but they're not going to continue replicating in some cases. So anyway, I want you to know about the blocking of those of the cell receptors on the tumor cells. So and you may need to use like antidepressants or some other CAM therapies to reduce discomfort from hot flashes. You can't use exogenous estrogen. You're not going. It's not going to be safe to treat it because of that, because it's going to just really mess with the whole system. That's just going to throw everything off, and it's not going to work. So anyway, the hot flashes can be really, really, really uncomfortable, but antidepressants like Effexor and Cymbalta, I think, and I can't always remember all of those generic names, but anyway, there are several of those that can help with sometimes it can make you feel depressed, but sometimes it really can work for the for the hot flashes. So anyway, realize that many hormonal therapies can increase the risk for DVTs, and do keep this in mind. Kind of highlight that, because even with patients like prostate cancer patients use hormonal treatments, and they can be at risk for DVTs also. So if any of these hormonal treatments, hormones can really get to you with issues with the DVTs. We did have, I remember 2 patients that ended up with DVTs. That one of them was taking a real long trip, just driving to Texas, and when she, I think when she came back home and drove back, she it ended up with a DVT, and she was on tamoxifen. And we had another lady that she had a really good functional status, and she went to Europe, and then when she came back from Europe, and she had been taking the tamoxifen the whole time, just being on the airplane was and not being able to move around, that made her have a DVT, and then it was kind of stimulated by the tamoxifen too, or it just they came together, the multifactorial thing. So anyway, just remember that any hormone treatment, it's not just for women, it can be for men with prostate cancer. So Herceptin, this is the one that is a targeted therapy, and there's a picture on the handout that I have. I think I'm gonna stop this for a second and see if, let me get speaker view. I'm not sure if I can get, can y'all kind of see what that, I don't know if you can see the whole thing, but it is, one of the first one has just a one little HER2, it's human epidermoid receptor 2, and so it's you're supposed to have a little bit of it, and it's normal, and but then when you look at the abnormal, it looks like a whole bunch of peas way down in here. There's a whole bunch of peas, and so those little peas in the pod are not supposed to all be there. You only need one pea. You need, and this is just sort of a cartoonish kind of thing, but if that helps you, you can look at the cell has right here, it has a little dot on this. I mean, I can't get it to do. Okay, it has one little dot for the normal, and then there's a whole bunch of them on the cell, on the outside of the cell, and so it's encouraging. That's what's encouraging to divide in abnormal ways, and that's one of the things for breast cancer. So do look at that one really carefully, and refer to any of these ones that I've told you that I want you to know about. Look at my chemotherapy classification group handout to just get you a little more information on those specific ones that I want you to look at. Okay, so let's see. Okay, the amplification and difference in normal and abnormal expressions of the gene. So that gene amplification was where you see the whole pod of peas, and it's only supposed to be one. Okay, so it means that it is a more aggressive tumor when you are HER2 positive for breast cancer. It's overexpression of that gene, obviously. And then it's only applicable for about 25 to 33% of breast cancer patients. The thing is, you weren't able to do much for people with HER2 positive patients. They were just going to get their chemotherapy and their tamoxifen and all that, but they didn't have any way to block that HER2, where they couldn't suppress that HER2 problem. And so it's only about 25 to 33% would have that, and it was more difficult to treat, and the patient would be more likely to progress and die from that. But now that we have the targeted therapy, sometimes it's really even better to have the breast cancer with the HER2, because we have multiple targeted therapies now that started out with Herceptin, but they've evolved from Herceptin. Like if there's a problem with the Herceptin, you could maybe add another type of targeted therapy also, and so the people that don't have HER2, it's not going to work for them. So you're not going to take that if you're not HER2 positive. It's all kinds of tests are done on the tissue for when you are diagnosing how much the mitotic index and the differentiation and all those kinds of things. They look for HER2 also, and they look for estrogen receptor positive or estrogen receptor negative. You're not going to give somebody tamoxifen if they are not tamoxifen or not estrogen receptor positive. So it's not going to work. So estrogen receptor negative patients have to take something different, and it's not usually hormonal. So anyway, so it means it's a more aggressive tumor, but it does give extra treatment options in addition to surgery and chemotherapy that HER2 negative clients don't have. And that drug does bind to HER2, and it turns off the overexpression of that gene that's trying to encourage that uncontrolled cell division. So it also, some of its side effects, or it can cause infusion reactions, and over a period of time, for some people, it can decrease the ejection fraction in the heart. So it can you may have to have some testing done like before you start taking Herceptin, just to make sure you're not going to cause more damage. But you got to watch it real closely to do like a echocardiogram, and you can tell how much blood is being pumped out with each heartbeat from the left ventricle. So that's one of the risks of it. So if somebody already has some problems with their heart, you got to either watch them really closely or maybe try to do it a different way. But it is a cumulative type of issue.
Thank you, Joe.
Oh yeah,
I just want to clarify that the tamoxifen, you have to be an estrogen positive.
Yes. Yes.
And the Herceptin, you have to be the HER2 positive.
Yes. You got it. Yeah. So when it is about tamoxifen, is about the receptors. Yeah, the estrogen receptors are blocking the estrogen receptors, and then with the HER2, it's blocking a signal to that would, because it's a gene kind of a signal, and it comes from a gene, and so it's going to block that signal that for the HER2 to grow.
Thank you.
Yeah, yeah. All righty, thank you. All right, so I've got, let's see here. Let me get back to my screen here. Okay, this is something that I found from a newsletter. I think it was from Oncology Nursing Society or something like that. And this was an old poster. Mustard gas smells like garlic, horseradish. Mustard is a strong vesicant, and World War II gas identification posters. It was from 41 to 45 during World War II. So anyway, but I'm going on my notes page, kind of going from my Herceptin. But I do want you to be aware, just flip through that chemotherapy sheet just to be aware of how complex the cellular regulation process is and how many ways we're trying to intervene with the process when it turns cancerous. And there's so many targeted therapies now that I don't know, I probably have a whole bookshelf full of them now that they're coming out like crazy. But anyway, more and more new drugs are being approved every month and probably every day now. And scientists are continuing to research the new combinations of interventions to suppress the cancer growth and destroy the cells, the cancer cells, and encourage the body's own immune system's surveillance for the abnormal cells. There's lots of things going on there. And it is the signaling. It's the transmission of the communication that goes between cells and within cells. So anyway, this isn't on my sheet, but look up the Zofran, which is ondansetron. Remember the ondansetron more so than the Zofran. So the Zofran is the brand name, and ondansetron is your generic name. And so that's for your antiemetic use. And that was the first one. It was a 5-HT3, they call that, and it blocks serotonin in the GI tract. It blocks the serotonin from going up through the nervous system up to the central nervous system up to the brain, to stimulate the vomiting center and the nausea center in the brain. And so yeah, that's I always thought that serotonin was just mainly in the brain, but I think I showed y'all that little video about the GI tract is the second brain, and you can look at that again if you want to. But yeah, there is serotonin being produced more so, maybe even more so in the GI tract than in the brain, and so it's gonna send it up the vagus nerve, and so it's trying. That's what ondansetron does, is block that. So Anyway, with radiation or chemotherapy, you're going to do it with preventive. Well, you can do it treatment wise, therapeutically, but you can also do it prophylactically. And that's what we want when we know that those medications are really terrible, and especially nitrogen mustard, which the nitrogen mustard was the first medication that was used for chemotherapy that was a toxin. So, all right. Okay, and when you do use that Zofran, you're going to be encouraging regular doses orally for about 72 hours after the therapy. So if you get it IV before your therapy, about 30 minutes to an hour before your therapy, okay, that's well and good. But once you go home, you can try to take it orally. And there is one that's like let's see, ODT there's a Zofran ODT that you can just put on the tip of your tongue, and it just melts away, just like powdered sugar. You don't even have to put it under your tongue; it's on your tongue. So if you can't swallow, if you're really really sick, and you can't swallow, you can have it absorbed that way. Okay, and so yeah, it takes about 72 hours for those emetogenic drugs to get out of the circulation, like the toxic drugs. So do know the radiation and chemotherapy side effects from my sheet, and refer to not the concept book, because y'all don't have that, but the Kaplan Basics has a good outline for interventions too. So you don't need to know the differences and details about all the classes of chemo. You got to know those drugs above, and those are listed on the practice problem thing too. And I think I explain a little differently on that one. So do know the concept that there's multi-drug combinations in most treatment regimens. And so it's often necessary for that for maximum cell kill and minimum side effects. You can't just use one drug and keep giving more and more and more of it, because you're gonna need to know the word nadir, and it's the low point. That's where there are a number of chemotherapy drugs that do cause a decrease in the production of the white blood cells, and somewhat red blood cells and platelets too. But the white blood cells, neutrophils in particular, are the ones that are that live the shortest period of time. They're just churned out. And since they're growing so fast, they're the ones that are more susceptible to the toxicity from some of those medications. So that's the low point between treatments. If you've got like a treatment once every 3 weeks, it's about, the nadir would be about like at 1.5 to 2 weeks or something like that. The nadir would be like the lowest point of the white blood cell count, and especially the neutrophil count. So and again, mostly neutrophils, it says it on the notes page, and it can differ with different chemotherapy drug classes too. So what we're trying to do is mix these. Like there's some like vincristine, the ones that they're in the mitosis phase is where that is where it works the most, but that can cause some neurologic problems. So if we've got something that works for a particular medication or a particular cancer, if it will work for that, and if you can combine it with something like cyclophosphamide that will cause problems with the neutrophils going down, and then there may be another one like one that's dealing with folate, and it would be like fluorouracil. You can have mouth sores, and so you can combine some of those that they will work, but you don't want to have too much of any one of those, and you don't want to have your your blood cells to bomb, all over the place, and that can cause death if you don't have enough protection from those neutrophils, and for a very extended time, then it can be life threatening. So we have to make combinations. So you're gonna, it's sort of like a recipe, and then they do lots of experimental. I guess you're doing lots and lots of research about how to join all of the medications together, and it's gonna that type of research is going to be going on for ages and ages and ages, and they're adding targeted therapies to these toxicity type therapies. So I want to get on my next page here. This was on that same.
I have a question.
Yes. Uh-huh.
So when you're doing the combo therapies, you do not want the same nadir because there'll be a lot of cell destruction. You want to combo like 2 different nadirs to get it to work.
Okay. Yes.
Thank you.
Yes, and some of them like vincristine, or it's called Oncoven. But anyway, it does not really cause a nadir, but it does cause problems with your nerve endings, and it could cause like paresthesias where it's gonna make you not be able to feel your fingers as much, or it may be sort of tingling or numb, and you don't want to. It can be progressive if you take too much of that too. So yeah, you want to get it just right. Okay, and so the nitrogen mustard, the mechlorethymine, it was the first chemo drug approved by FDA as a result of the hematologic side effects from the use as chemical warfare agents in World War I. And a toxic effect was to decrease or arrest the cell proliferation in the bone marrow, and where the bone marrow or the blood cells are produced. That led scientists to research whether it would decrease the abnormal cell proliferation in the cancer patients. And so it took 32 years to get approved because they knew that it killed, especially if somebody had leukemia and you're making too many leukemia cells. And so that it was like, well, if you're being toxic, you're killing people by killing their bone marrow with that nitrogen mustard. Well, maybe if somebody has leukemia and they have too many cells, maybe we can find a way to treat it with that particular chemical. So, and it was very, very scary, of course. So 32 years to get approved after the first use as a weapon in 1917. And then, so our different kinds of therapies it's along with surgery or radiation or both adjuvant. And like we have adjunctive clinical faculty, like that, where they're in addition to the regular full-time faculty and stuff like that. So an adjuvant therapy would be something in addition to the primary therapy, which would be a lot of times it might be surgery, and then you have radiation and chemo after that. So those are the adjunctive therapies, and it's only in potentially curative situations. And then neoadjuvant therapy. So neo means new. And if you can do this before surgery, so that if sometimes there are really some large tumors that you just don't want to make it so invasive and so much to have to take out, and it can be this disfiguring and all this kind of thing. So if you can do some radiation and or chemotherapy ahead of time before you do the surgery for just maybe 2 doses or something like that, or just a few doses to shrink it some. And once it's shrunk, then you're not going to have near as big of a problem with having to take out just a huge huge chunk of your, and maybe it didn't have to be just breast, it could be other types of cancers too. So even in lung cancer, you can do neoadjuvant, do some radiation and some chemotherapy, and then take X-rays or MRIs or CTs and see if it's shrinking. And if it's shrinking and to a point to where it's much safer to do the surgery, then you would go on and do that. And the surgery would actually be the primary instead of the neoadjuvant. So then the concurrent therapy, there can be radiation therapies along with especially some colon cancers and rectal cancers. And sometimes it's very specific timing of each treatment modality to get the greatest response. And often in head and neck and rectal cancers is when they use like fluorouracil. Y'all don't have to remember the name of that one, but that is one that they use. And they may give the radiation first, and then the chemotherapy, and then they do the radiation again or something like that. They make a regimen of it, and it's you have to do experimental treatments before it's a standard, but it can be pretty much standard for certain types of GI cancers. All right. We're going to do our methods of administration now. So oral and subcutaneous, IM, IV, intracavitary. So that could be inside the abdomen or inside the thoracic cavity. Intrathecal, that's into the cerebrospinal fluid, and intraarterial could be like they can have these pumps that go that push into the arteries of the liver, especially. There may be other ones that you can use, but the liver is the one that was first used for intraarterial pumps for somebody that had maybe colon cancer or stomach cancer that spread to the liver, and they got it right. It was more of a localized treatment, and some of it would get into the bloodstream all over, but most of it would have already acted in that specific area. So that was less problems with side effects. And then topical is when you just put it on your skin or your mucous membranes. And then, so our regional administration, delivery of the drug directly to the tumor site, and higher concentrations can be delivered with reduced systemic toxicity. That's what I was talking about that on intraarterial particularly. And then intraperitoneal, and I think I mentioned about that you can put it's called a Tinkoff catheter. That's what we used to call it a long time ago with dialysis. But anyway, it's like a dialysis catheter, and you can put like a medication into it, and you dwell. The medication will dwell, and then you let it go and rinse it out. And so it can if there is that plaque of cells just all covering the peritoneal membrane, then that's a good way to get it right there, and it doesn't have to be absorbed totally into the system, not into the bloodstream. So, and then our intrathecal or interventricular. And so the intrathecal is when you do a lumbar puncture. It's like a spinal tap. You can take a little bit of spinal fluid out. Our doctor would do that. The nurses don't do that. But the doctor did. And then the doctor would get into the spinal column and get some spinal fluid out that's like 5 mLs or something like that. And if they needed 5 mLs of the medication, you just replace that volume, the 5 mLs of the medicine, and then it would go through the central nervous system and cause the killing of any of the cells that might have been in there. I guess originally that you would take a lumbar puncture and see that there were cancer cells in the cerebrospinal fluid, and so you're trying to kill those with the medication that you're putting into that cerebrospinal fluid. And you can do it into the the ventricles of the brain. It's like a portacath. I guess y'all had seen portacaths when you saw central lines. Did you see that model of a portacath? Hopefully, that's got you have to go through it with a needle, but it's left in there for a long time, a longer time than you would a PICC line kind of thing. But it goes up into the ventricle of the or one of the ventricles of the brain, and it's called an Ommaya reservoir. You don't have to remember the name of that, but it is a cool thing is because if the patient has to have multiple sessions of treatment and having to do a lumbar puncture every time, that can really cause some scarring in that area, to get into the spinal column so many times. So that's why some people, like especially with lymphoma, we did have a lady with lymphoma, and so our doctor would do that treatment too. He would take out the fluid and then put the medication in, and it was so much easier and so much safer for the patient. And intravesical is bladder installation, so you can put a urinary catheter in and then sort of have that dwell. You clamp that off, then clamp the catheter, and then you leave it in. You let it dwell in the bladder for a certain length of time, and then let it out into the bag. So you have to be real careful. You have to wear gowns and gloves and all to so that you don't get exposed to the chemotherapy. So the easiest way to describe how cytotoxic therapy works is that it damages DNA in some way, either directly causing the cell death or interfering with the cell division. And cells that are dividing are a lot more sensitive to the cytotoxic effects of chemotherapy. And the normal cells that are most sensitive to chemotherapy are those that undergo frequent or rapid cell division, like hematopoietic cells in the bone marrow, that are dividing, skin cells, mucous membranes, GI tract, hair, reproductive cells. And then cancer therapy does become a tremendous ethical issue if the client's diagnosed and needs treatment during pregnancy. And we did have, at least 2 people that I remember. There's probably more than that, but that have had diagnosis of Hodgkin's disease, young women, and both of them were pregnant. It wasn't at the same time, but anyway, one of them was just newly pregnant and just found out that she was pregnant, and she decided to just go ahead and abort because she needed to have her treatment. She felt like she needed to go ahead and with the treatment and then maybe have a baby later if that would be possible. And so she did abort. But then the other lady she knew that she was pregnant, and she may have been a little bit further along too. But she did decide not to take her toxic chemotherapy, cytotoxic chemotherapy, until after the baby was born. And so then she went through real aggressive treatment afterwards. And so both of them did well for a time. I don't know how long, that if you have really a cure, sometimes the patient's released from the oncologist after several years, and so they may have moved away or whatever. So I didn't know what happened in the future there, but that's a big ethical. I'm going to grab my phone because I've got it charging here. Okay, so this is probably a good time to take a break here. So let me get out of this for a little bit.
So Ms. Beaver,
You
just want us to know how it works when it comes to cytotoxic therapy. That's all you need us to know? Good. Thank you.
Well, you do need to know those specific medications that I told you about, though, to how those work, because I'm picking out.
Yeah.
You've got pages and pages, and so you need to know more about those, how they work, and so that's I just picked out those from different categories. So yeah, those ones that I had picked out for you, and the one they're on the end of the practice problems too. Those are the ones that you really need to study.
Okay.
All righty. Well, I'm gonna pause the recording. Guess it's about time to start back up now. So I'll go back to my share screen. But I'm going to get our recording done first.
Ms. Beaver.
Uh-huh.
I have a quick question about the practice problems. The one you wrote for 211 and the one that has, maybe I'm repeating the question, the one that has the meter square and the one that has the rod, we're not going to have it on this test, right?
It'll be the only ones that are going to be on this particular test. This is one that was some extra problems and stuff. Now the one that there's another document listed under there that's the one that's going to be for the test, and it's going to be the same kind of problems, but just the numbers will change, like we did in 111.
You mean the 5 questions?
Yes. Yeah.
Okay.
So if you are understanding those, don't really worry about the rest of that. Okay. Because it could be very, very confusing. I'll leave it there just in case people, maybe want to delve into it deeper or need to delve into it deeper. But if you're understanding those 5 questions, you're in good shape. Yeah, those 5 math questions. So yeah, you don't have to use all of that in the practice problems, but do use the notes at the end. Definitely do that. Okay, so I am on our injury from the vesicant drug. So when vesicant drugs infiltrate or extravasate outside of the vein, there can be skin damage or subcutaneous tissue damage, like your adipose tissue, and it can be nerve and muscle damage. And the drug doesn't readily reabsorb from the tissues back into the bloodstream to get diluted and metabolized by the body. So there's great concentrations that can remain in those tissues and continue to cause damage. So we don't really want it in our bloodstream, but we don't want to have it eat away at our hands or arms too. So y'all do have I think I have Iggy 22-2 figure, and it looks worse than this one does, I think. But anyway, there are several antidotes that you can inject after extravasation of the vesicants. But the best thing to do is prevention. And the chemo nurseman has to constantly watch the vesicant infusion sites until all the drugs been administered for early detection of possible extravasation. Sometimes you don't see it. Sometimes there is some that leaks out that you don't know about until it starts to swell really, really greatly. But central lines they're most often used for the vesicant administration, and they aren't foolproof either. You do need to be careful about that. You do need to be assessing carefully for the extravasation. And so, and you had some slides posted. I did have some slides posted from the. It was really from your. your checkoffs, you know, when you were learning about central lines, that because I think I told y'all I had been teaching the central line part before we started bringing in students in the spring, and so I wasn't able to do it then. But if you do want to you know, review that a little bit or use it later on in clinical, that you can certainly, you know, look at that and see how you're supposed to take care of it and how important it is to keep things sterile and that sort of thing. So peripheral vessels are unwise to use for continuous infusions if it's going to be like over 24 hours or something like that. There are some regimens that do that. So you want to make sure that the patient has a central line if they're going to be like going home with a pump to take a 24-hour, or sometimes it's a week long. There's some of these colon cancer regimens have a week long. They have a pump that they use, and they start on Monday, and then they come back at the last minute on Friday and take it loose. But anyway, we don't want to use peripheral vessels for any of the, well, either irritants or vesicants, now that we know that we can use the central line and it's much more safe. So yeah, the vesicant drugs are when they infiltrate like that, the inflammatory process starts taking over, and it tries to wall off the injured area. But what happens is since it's not diluted by blood or anything, it just keeps attacking and attacking and attacking, and the inflammatory process is not really helping at that particular point. And so you can end up having to have a graft to put over that, or you may have to have some surgery for nerve damage. So it's the prevention is really, really the key. Okay, so our effects on normal tissues, and this unit is real general. I mean, I know there's so much stuff here, but it still is general. We'll talk about more specific things in 211. But with acute toxicity is vomiting and allergic reactions and arrhythmias. And we will be talking about allergic reactions and immunity unit before we do the cancer unit in 211 also. And then delayed effects like mucositis, and that's mucositis is having a real sore mouth, and sometimes it can even look like just like raw meat inside the person's mouth, because it can really do that, and it's so painful, and it may even the patient may even need opioids to relieve the pain. And salt and soda rinses are really, really important. We don't want to use peroxide. People used to use peroxide with that, but don't, because peroxide eats away at protein. So we don't want to do that. We want to have new mucous membrane tissue inside the mouth. We don't want it to wash it. We don't want the peroxide to wash it away. So salt and soda rinses, and so it's about like a half of a teaspoon of salt or soda to a cup of water. And it would just have it warm, not just a little over room temperature, just warm, and it's very, very similar to isotonic, like for our saline, our normal saline 0.9%. It's very, very close to that. So when you think of salt and soda and you got a sore mouth, you think, oh gosh, salt in a wound is horrible. But if you have it in that particular measurement, that can be very, very soothing. So alopecia is hair loss. Not all medications cause hair loss, and alopecia is not going to happen if the patient is taking radiation, like on their like on their hip, if they're taking radiation in their hip and they have bone cancer or a metastatic area in their hip. So you're not going to lose the hair on your head if you're having radiation on your hip, because the radiation is a localized treatment. So, but now with chemotherapy in the system, in your whole system, some medications can cause the alopecia, definitely when you get all of that through your system. And bone marrow suppression means that you're not able to make as many, especially neutrophils, as you would normally have it, because they churn out, and they live less than a day. So it's like 12 to 18 hours, I think, is what one of the sources said. But I read another source the other day, and it was more general. Less than a day, they live less than 24 hours. So chronic toxicities, damage to your heart or kidney or liver or lungs, and they can be lifelong survivorship issues. There, especially when I was talking about the lungs, that fibrosis could be permanent. And sometimes even the neurologic problems can be permanent too. So I'm not going to talk much about the bone marrow transplant. It is a treatment option for some people. We're using more stem cell transplants. That sort of that has evolved from bone marrow, and we'll talk more about that in 211. But there's certainly a treatment option for that. And so if you have an anti-neoplastic regimen and bone marrow transplant, that can result in immunosuppression, and the transplant patients can be at high risk for infections from bacterial and fungal pathogens. And the pathogens that are commonly in our environment, like fresh fruits and vegetables, are ordinarily not a hazard to healthy people, but if you've got problems with your immune system, you want to be real careful about what you eat and how you eat it. So a low bacterial diet is indicated whenever the plasma neutrophil count is less than 1,000 per millimeter cubed, whatever. It's starting to be a controversial issue, though, because some folks have done, or some hospitals have done some experiments with that to see if it really makes any difference. But that seems like it would be a real difficult thing to experiment with, because if you're giving people food that's like not peeled, like apple that's not peeled or something like that, what if they do get an infection and die? So it's real hard to research this. So I think it's sort of a theory type thing that sometimes it's just not ethical to do things like that. And so we don't know for sure if it really makes a difference to have foods that are cooked instead of raw, and have salads and things like that. So but we want to be cautious about it. We don't want to cause some kind of a problem. Okay, so our food safety guidelines for patients with a low immune function, or if they are neutropenic, you avoid undercooked meats and eggs, and ensure that raw fruits and vegetables are washed well and are peeled, including salads and garnishes, and follow the appropriate sanitation guidelines for food preparation and storage. I have this 4th edition thing, but it's probably, I don't know how many other editions we have. But if you have the one of the nutrition books, then you can look through preparation and storage, and you can actually Google stuff like this now. But you want it to be one of those sources that's going to be something that you can trust. And especially that NIH and the National Cancer Institute, a part of the National Institutes of Health, you can go to, you can do cancer.gov, and that's one of the websites that I've got posted. But you can go into that and ask about food safety for for patients with low immune function or something like that. If you have a patient that needs to be in, and I guess sort of protective, maybe not protective isolation necessarily, but be use all kinds of protective interventions instead of just guessing whether things are safe or not. So anyway, people with cancer can have a low white blood cell count for a variety of reasons. And sometimes it's because of radiation therapy, chemotherapy, or the cancer itself. And so the patients that do have a low white blood cell count are at an increased risk for developing an infection. And people that have too many white blood cells, which it would be leukemia, and they're not normal cells and they're not working. They just turn out abnormal cells that don't work. They don't help your immunity. So that's a risk factor too. So these are suggestions for helping people prevent infections related to the neutropenia. Check the expiration dates and don't buy or use it if the food's out of date. Don't buy or use foods that are in cans that are swollen or dented or damaged, and thaw foods in the refrigerator or the microwave. Never thaw foods at a room temperature, and cook foods immediately after you thaw it. Refrigerate all leftovers within 2 hours of cooking, and eat them within it used to say within 24 hours, and I was scratched through that because I looked at it on the website, and it's 3 days. It says eat them within 3 days, but it's really better to eat for the patient to eat it, the food just when it's fresh, and then let the rest of the family eat the leftovers and fix something fresh for the patient. I had read that too. And keep hot foods hot and cold foods cold. Avoid old or moldy or damaged fruits and vegetables. Don't use tofu in open bins or containers. Cook meat and poultry and fish thoroughly, and avoid raw eggs or raw fish. Buy individually packaged foods that are better than larger portions that result in leftovers. And you avoid leftovers if possible, or like for 1 to 2 days, but best for others to heat up the food and let the patient eat the fresh food. That's I don't know if I got that on y'all's notes page, but I had written that in. Use caution when eating out. Don't do salad bars and buffets for people that are immunosuppressed. Limit the exposure to large groups of people and people that have infections, and wash hands frequently to prevent the spread of bacteria. And the list can be modified after chemotherapy or when the blood count returns to normal. And we're in this with this COVID stuff. A lot of those things are like the hand washing and staying out of crowds and things like that is kind of what we're kind of all in that right now. All right, our treatment plan. The drugs that are used are effective against the cancer being treated. That's how you plan. And then your synergistic effect occurs when combined. So synergy means that when you do combine several different types of drugs that do work against the particular cancer and don't have the same naders or don't have the same side effects like sore mouth or nerve problems, but synergy is like it's sort of like more than the sum of the different parts. So they can work together more effectively. And so synergy. So that's one of those words. I hope y'all can remember that synergy is it works together. Okay, and then it includes the cell cycle phase specific and cell cycle non-specific drugs with different mechanisms of action in different parts of the cell cycle, and some of them are cell cycle non-specific. So you want to have some cell cycle specific and some cell cycle non-specific. So the combination of drugs with different toxic side effects, and it includes the drugs that cause the nadir, the lowest level of the peripheral blood cell count secondary to the bone marrow depression at different time intervals. And that's what y'all were asking about, and that's exactly right. So the bone marrow and peripheral blood stem cell transplants are thoroughly discussed in Understanding Cancer series listed in under the cancer websites, and it used to be a PowerPoint, and now I think it's in PDF form now. But if you're interested in that at some point, but we will discuss this and when we have our exemplar for leukemia in the summertime. Okay, so our biologic therapy, and this is our interferons. So the side effects, like I said, the interferons fight viruses. So flu-like syndrome, the fever and chills and achiness, anorexia and weight loss. You just are not hungry. You just don't want to eat. You're tired, you're lethargic, you're just real out of it. You just don't feel good. You can have, actually, this was added in probably about 10 years later than we knew about it anyway, and depression can be part of that. So it is an issue with our brain. And also our serotonin levels. I don't know exactly how that works between the GI tract and the brain to cause some depression, or because serotonin is supposed to be a feel good in the brain, but so it probably is creating an imbalance of some of those neurotransmitters. So changes in the cognitive function and bone marrow suppression. Bone marrow suppression, though, is not nearly as common as it is with cytotoxic chemotherapy. It could suppress the bone marrow, but it is not often. What is often is the flu-like syndrome. So I want you to keep on really emphasizing that in your head, that the biologic therapy causes flu-like syndromes, fever, chills, and achiness, and interferon is our prototype drug for this. So our nursing interventions for flu-like syndromes, and this is very simple here. You monitor vital signs, plan rest periods, and assist with ADLs if you're in the hospital or in a long-term care or something like that. Administration of acetaminophen before the treatment and about every 4 hours after the treatment for a few days, or depending on how they feel. And then if the patient does have severe chills, they call it rigors or rigors. It's really, really hard shaking chills. And I had a patient that had that one time. It wasn't from interferon, but it was from another type of biologic therapy. And he was just shaking so hard out. I mean, and it was so stressed. It was stressing his breathing and everything too. We ended up having to call an ambulance and have him taken to the hospital. It was just a block away, but it really did. The hard and shaking chills really that can mess you up if you have a weak heart to start with, and then you have those hard shaking chills. That could cause potentially death, really, if you don't get that straightened out. But this is really weird. We don't really understand how this works, but IV meperidine, I think I mentioned that earlier, but IV meperidine, which is Demerol is the brand name, and it does, if you do it intravenously, treat intravenously, it will stop those hard shaking chills for some reason. So, and we don't use it as much for pain relief because it is an opioid, and we used to use that all the time especially when I first got out of school. It was like meperidine and Phenergan, and so it was called Mepergan, and it was mixed together after surgery and stuff. But now they know that there's a metabolite in meperidine that can cause some issues, and I can't even remember what they are. I think that may have been some cardiac stuff too, but it does, and if you do have those rigors or rigors, it usually will stop, and it shouldn't come back unless you give them the same thing again. So And then what I do want you to remember these 4 words when you're planning interventions for biologic therapy and therapy-induced flu-like syndrome. So remember, interferon is flu-like. So that's why your interventions are going to be based on making the person feel better or some prevention. Pre-medication can help with that acetaminophen, the Tylenol. And you're going to monitor vital signs. Is the patient, what's going on, or do they have an increased heart rate or anything like that? Or are they having breathing trouble? And are they especially having a fever? And then you're going to have them rest because they're going to be really tired. It does take a lot of energy out of you. And then assist. So pre-medicate, monitor, rest, and assist. So please remember those 4 words, and that's what you can work on with the interferon. It's a simple thing, but remember that's the one that we're aiming at, or the biologic category we're aiming at. Okay, so skip a page here. Monoclonal antibodies are capable of binding to a specific target cell to ultimately destroy them. And that's how they started working with this, was to get to a specific cell to destroy the cells. But what they're doing now is to suppress the transmission of information and communication, like I just said, within and among cells. You can do this with target cells, but you can also do monoclonal antibodies for other chemicals that cause suppression or turning on or turning off inflammation. So many are administered by infusion, but some can be taken orally. You can experience an infusion-related symptom, even anaphylaxis possibly, and then some oral agents can cause severe skin rash. That's what we have been finding. So there are dozens of targeted therapies that have been approved by the FDA. That's what I have on my notes page, but it's more than that now. It's in the past several years, and they're just cranking them out like crazy. So the combination of surgery and radiation and chemotherapy, biotherapy, targeted therapies, all together can be used on an individual patient. And many do target very specific gene mutations now, so that one individual that has multiple types of mutations might be eligible for multiple targeted therapies. And the bad thing about it is the cost. So it can be a really high cost if you really need all of those factors that you're needing to be paying for the medications. And there can be with some of these targeted therapies, some people can respond really well to it, but then they've done some experiments with this too, and did statistics on it. The average increase in life expectancy survival has been only 2 to 3 months longer than they would have had as far as what the expected life expectancy would have been with that particular diagnosis. And it's been very disappointing sort of earlier on in this, but I think if they can get the right cocktail, kind of like what we were talking about with President Trump, they were talking about that on television, that he had some type of a monoclonal antibody cocktail type of thing. And so, but I think it's going to be, I think it is improving. It's not going to be quite as disappointing if we're able to get people to be able to afford the treatment that they need. Though that's the part that's so sad, I guess. You can say it's sad if the patient doesn't have good insurance, and even if you have good insurance, sometimes it can bankrupt you. All right, so our hematopoietic growth factor. So hopefully everybody has already done that. I've graded most of them, and I'm going to do some more grading this afternoon. But the colony stimulating factors, they are glycoproteins that stimulate the production and maturing and regulation and activation of cells in the hematologic system, and they might hasten the recovery from the bone marrow depression or reestablish the bone marrow function. So we were talking about white blood cells, red blood cells, and platelets, and those factors that were in that article. So hopefully that y'all are into that. So our granulocyte colony stimulating factors are the Neupogen and Neulasta, and actually. The granulocyte colony stimulating factor, there is a brand name, it's filgrastim, and I don't think we even had that word in the article. I don't think they even put the filgrastim in that. Maybe they did, but Neupogen and Neulasta, when you have the NEU, that does give us even in our brand name that you can tell that that's a neutrophil issue. So that's but now the filgrastim, that doesn't make a thing to you, but a granulocyte colony stimulating factor is that's what it is actually. So we use that filgrastim, and if you're going to do test questions and all, we have to do the generic name. So, but it actually is a granulocyte colony stimulating factor. So, and that's what CSF is, or GCSF. So, it's responsible for stimulating the granulocytes, or the neutrophils, in the production for the phagocytic activity as the first defense against infection. Okay, so I do look at this sort of orangey looking warning here or whatever, and it can cause bone pain that can require analgesics. That's due to packing of the bone marrow with a rapidly proliferating cells before being released into the bloodstream. It just can work too well for some people if they take the granulocyte colony stimulating factor, or Neupogen or Neulasta. You can sometimes it goes overboard, and it causes lots and lots of pain in the bones where the bone marrow is. And so I just want to tell you about this, where the bone marrow is located. You can have the most of the bone marrow is going to be in your sternum and in your hips and pelvis. And in the long bones of your arms and legs, like your femur bones and your humerus, not the ones that are more peripheral, but the humerus bones and the femur bones, and those have a lot of bone marrow in them. And you can also have bone marrow in your skull and in your back, in your vertebrae. And so bone pain could be at any place. Sometimes people have a headache because it's accumulated so much in the skulls, and or the back, or your legs, or your arms, or your hips, or your chest. Sometimes people have thought that they were having a heart attack because their sternum they were hurting right underneath their sternum. So they went to the emergency room, and then they found out it was the bone pain because it had gone overboard, and the bone marrow had not released the cells out into the bloodstream yet. And so they just were packing in there in that particular spot. So somebody could just feel like they're having a heart attack. So I do want you to know that bone pain is the major side effect. There are others, but that's major. All right, so myelosuppression can be a side effect of radiation or chemotherapy, and it does involve absolute neutrophil count, like the ANC. And if it's less than 1,500, then you just don't. Sometimes you won't take chemotherapy. It depends on, maybe they're on a regimen, that experimental regimen or whatever. But usually it needs to be at least 1,500. Neutrophils. So we would do the calculation of the ANC by multiplying the total number of white blood cells. They're called segs or polys, the neutrophils, and then the plus the bands and the stabs, and 2400 you got 22% bands and 3%. No, yeah, 22% segs and 3% bands. So you're doing 2400 times 25%, and then you get the absolute neutrophil count of 600. You are not going to have to do that math now. That's just one of the issues, and it does affect whether the patient can take their medication or not. So that's why I'm telling you this, but that shouldn't be on your test now. We'll do that in the summertime. So the client might need antibiotics and or the GCSF. It depends on the facility. The neutropenic clients can be put in protective isolation for a low ANC, below 1,000 or 1,500. And in those questions that I was giving y'all about the growth factors, it was, some people put 1,000, but then in the text, it was really about like 500 is even worse. And so that's why I counted some of those wrong. Y'all did really good on all of that stuff too, because it was just 1 point for each blank there. And I tried to go through and tell you what that right answer was. Some of y'all made 100, and almost everybody had in the 90s anyway. So y'all did really well with that. And then you usually do need frequent temperature checks if there are any bad days when they don't feel good, and especially if they experience the chills or the signs of infection like chest congestion or dysuria. And if they're febrile, over 100.5. And more recently, some places are counting it as just 100. If it's over 100 at all, then you do contact your oncologist. So that would be that sometimes you might see cancer patients admitted to the hospital for febrile neutropenia or for antibiotics and protective isolation and colony stimulating factors. Okay, so our erythropoietin, the Procrit and Epogen, and CSF is responsible for stimulating the growth of erythroid precursor cells that mature into red blood cells, and it's made by the kidneys. That was in your article too. Darbepoetin is called Aranesp, and it's a longer acting and less frequent dosing. And you remember at the end that it was talking about biogenerics. There are lots of biogenerics out now, evidently. So these are just the ones that were originally around, and so there's probably going to be lots more that you will find. So they can increase coagulability and possible cardiovascular events. And you can see the web-based assignment, of course, on the growth factors that you just did, and the recombinant DNA process for the colony stimulating factors, and to supplement what the body produces, because we have erythropoietin in our body. That's how we make our red blood cells, but this is like a supplement, and it is from the recombinant DNA process how they make that. Okay, and our oprelvicin is Numega, and it is a platelet growth factor. It increases the megakaryocyte production. The megakaryocytes are a whole cell, but then they break apart and become the platelets. So that's the megakaryocytes don't do stuff in the tissues or the blood vessels or anything, but they don't do anything until they break apart into the little platelet fragments. So it's indicated for preventing severe thrombocytopenia and a decreased need for platelet transfusions. So the adverse effects, though we stopped using this. Of course, I left the office in 2006, and we were starting to not use that because there can be edema and dyspnea and tachycardia and conjunctival redness, and can cause increased clotting too much. Because of course, if, like I was saying that Neupogen and Neulasta can go overboard. Well, when Numega goes overboard, you're going to have too many platelets, and if you already have coagulability, a lot of people with cancer have hypercoagulability anyway because of the cancer. And so then you take this to raise the platelets, but then that can cause a big problem, because you're going to end up having a clotting problem, and then that could possibly lead to death, or it could be very serious, of course. So our thrombocytopenia, the low platelets, is usually considered less than 100,000. And platelet transfusions may be necessary if the platelets are less than 10,000. We used to do to automatically transfuse platelets to patients when it was 20,000. But it's 10,000 now. But if there's active bleeding in clients with platelets that are less than 50,000, then you could go ahead and treat them with platelet transfusions. And they could do the Ubrelvec too if the patient's not hypercoagulable that they know about it, but we really were cautious about that. We stopped using it because of all that swelling and stuff like that. But the platelet growth factor can be used with caution. It could cause fluid retention, and peripheral edema, dyspnea. If the platelets are low, you're going to minimize or avoid the needle sticks or invasive procedures and avoid injury, and use the electric razor. You don't climb ladders or step stools, because if you fall off and then you bump your head, you may just, bleed. You may have a bad brain bleed, or wherever else you had contact with the floor. So avoid falls of any sort and prevent constipation. And I'm the elimination person and all that stuff too, but it's really, really serious business when somebody has extremely low platelets, and you just cannot have them bearing down so hard. So that's just it's a real risk for a bleeding type of stroke. Or you could blow if you had an aneurysm and you didn't even know you had an aneurysm, or even if you did know the aneurysm or that you had it, that if you're bearing down like that, that you're holding your breath and pushing against it. So monitor for hemorrhage and signs of bleeding. Okay, so we're going to be talking about some planning here, and on this I'm just going to have you look at on your own on the notes page. I just put some complementary therapies for cancer. Ginger is got some ginger candies, or sort of lozenges sometimes make people feel better when they're on chemotherapy. It decreases the nausea. And I wanted to mention the energy healing, that some people believe that cancer is a result of a disturbed energy field. That was on NANDA. If you all look at that, NANDA diagnosis, disturbed energy field, is one of those that at least had been accepted by NANDA. But anyway, the therapeutic touch and healing touch can affect the energy field of the human body and protect physiologic healing. And it involves placing the hands on or near the body with the intent to promote healing and restoration of harmony and balance of the body. And research has produced positive findings for these methods in a variety of cancer patients. And a lot of this touch thing and nearness to somebody too is there is some sort of an energy field evidently, but some people, I think a lot of it has to do with acceptance and everything too, and that can make them feel better. So it's I'm not saying it's a hokey thing, because it really can make a lot of people feel tremendously better. And I've seen that happen, but it varies from person to person, of course. So anyway, you can look at through some of those other things that might be or may have been done. So our planning is to focus on supporting the whole person and managing the specific problems, and you'll have the client to maintain weight within normal range and remain hydrated. Client and family will vocalize feelings, potential side effects of chosen therapies, list strategies for coping. This is our goals, but this is not all of them. These are just some samples of goals. So we've got some nursing diagnoses here. This anxiety, and we're going to do implementations for anxiety. We're going to assess the level of anxiety, and we can do it like 0 to 10. How anxious are you? And the reality of the threats too, that make the people feel anxious, and establish a relationship therapeutically, and encourage the client to acknowledge and express feelings, and review coping strategies that are used in the past, and introduce new coping strategies as appropriate if they haven't thought about that yet, and identify resources and provide specific information in a safe, calm, and quiet environment, and use crisis intervention theory. And stages of grief can be evident right at diagnosis: the shock and anger and bargaining and depression and acceptance with the Kubler-Ross. And again, I've already talked about that anticipatory grieving is like the potential for loss, the death or loss of body parts or function, or loss of significant person or animal or possessions, or loss of the social role. And open-ended questions assess the causes and the contributing factors to grief, and look into their support systems, and encourage sharing of the concerns in a trusting relationship with a nurse and patient, and teach the stages of grief, and allow time to make the decisions, and provide information on appropriate resources for support during the grief work. And then psychological support from the nurse during diagnosis: the active listening and supportive, avoid giving advice or false reassurance. I think I've mentioned that 2 or 3 times in some of these other slides, but provide appropriate information and be non-judgmental and available to the family, and never say everything's going to be okay, because you don't know that. And so you've got to go with it in a different way. Be honest but gentle and caring. Okay, disturbed body image. Discuss the meaning of the loss or the change with the client. Observe and evaluate the client's interactions. Allow denial, but don't participate in it. To assist the client's significant others to cope with the changes in appearance, and teach the client to participate in the care of affected body area, teach strategies for minimizing the physical changes, and teach ways to reduce alopecia, the hair loss. And then our Look Good to Feel Better program can give suggestions to deal with hair loss, consultations on wigs and free wigs that are donated to the program. Cosmetologists are associated, these are the cosmetologists that are associated with American Cancer Society. And they do help with makeup and cosmetics to improve image perception, not just the hair loss part. And they actually do have their own website now. It's lookgoodfeelbetter.org. And so that's one of the things that you could look up if you have a patient that's got some body image issues, having to do scarves and doing makeup in different ways to make your eyes look bigger if your eyelashes have fallen out, because that's a type of alopecia too. But anyway, also, okay, yeah, I just need to scoot on here. Just a second. I don't know if Ms. Walker's trying to get me again. Huh. Well, Okay, so monitor the vital signs and monitor the white blood cell counts frequently, and teach the clients to avoid crowds and small children and people with infections, and protect skin and mucous membranes, and encourage the client to consume a diet high in protein and minerals and vitamins. And we can have many potential causes. And if we're immunosuppressed, we may not be able to run a fever to help fight an infection, and might have to go by the white blood cell count value. So skincare and diet is very important, especially protein and vitamin C and minerals. Okay, and now we've got our risk for injury, and we're going to assess frequently for the signs and symptoms. There may be organ obstruction. You can teach the client to differentiate minor problems from those of a serious nature, and monitor lab values, assess for peripheral neuropathy. I think that's what I was looking at. I had it on a different page before, but tingling and numbness in the hands and feet is called paresthesias, and decreased blood pressure, and erectile dysfunction, dysesthesias, that's painful sensations like diabetic neuropathy would be, and decreased taste and severe constipation. And when to call for help, y'all can look through, there can be much more. All of these examples here, these are just examples of implementations, because there's just, the world's your oyster on a lot of these things, because it really does depend on the individual person, how you're going to do these kind of things, or what you are going to do, or what they are willing to do, or totally against something or whatever. So you really do have to individualize, but we are generalizing all of this at this point, and there's lots more that you can do. But do look through that, when to call for help, and do look at that oral temperature if it's greater than 100, because it does vary. But when I looked at this from the NIH site, it did say they're now going by 100, at least at the National Institutes of Health. So oral temperature, if it's greater than 100, go with that. And if they there's lots and lots of examples there that are there's unmanageable behavior, being physical abusive and stuff like that. That's when you got to call for help. But look through all of those samples, because there's certainly more to it. It's generalization. So in balanced nutrition, we're assessing the current patterns and evaluate the degree of malnutrition, and teach the principles of maintaining the good nutrition, and managing the problems that interfere with eating, and encourage small, frequent meals, because it's when you get really, really full, it may kind of turn you against certain things if you start burping or you feel bloated or things like that. So small, frequent meals and sort of grazing. That's what we would always call that in our office. So while they have things like cheese and nuts and stuff like that, or whatever they can eat. Some people can't eat certain things, and if you're allergic to nuts, you can't do that, whatever. But you're going to encourage cold and bland and semi-soft foods and liquids, especially if the patient's mouth is sore. And then you manage the nausea with the antiemetic drugs. And on chart 24-8 in the IGGI book, it says, it has some information about ondansetron in the book, if you want to look at that. And then teach the client to keep a food diary, and teach the client to administer parenteral nutrition if it comes to that. The family may need to do that at home, like you would have for somebody with anorexia nervosa. All right, so impaired tissue integrity. We are going to assess and evaluate what's going on with the tissue impairment, and implement and teach prevention of oropharyngeal infections, and implement and teach measures to reduce trauma, administer specific medications to control infection and pain. Again, these are just generalities there. There's, of course, lots and lots of things depending on what the individual needs. So it may be from the cancer itself, or the side effects from the treatment, especially in the mouth and the throat and the esophagus, because that really can cause problems with nutrition. All right, here's our last page here. So this one is it may be somewhat confusing if I don't tell you about all of this. So it's important in our evaluation to remember that outcomes may not include recovery. It might, that's what we want, but we need to be realistic. So our client can report the pain level of 3 or less, reduction in side effects of treatment regimen in general, and the client experiences no unexpected complications, and the client demonstrates appropriate dietary choices. So on this notes page, I do want you to look at that first part where it says rehabilitation. That is one of our exemplars, and it does involve the client regaining strength. And this is the goals for rehabilitation. The client regains strength, recovers from surgery or radiation therapy or chemotherapy or all three. Learning to live with an altered body part or appliance, and recovery from associated psychological and emotional issues. And this is something like from the survivorship site, a website, and so it may involve physical therapy, occupational therapy, or speech therapy, or job retraining, or direct nursing care and teaching. Again, the world's your oyster. There's so many things about that, but the website is really, really good. If I've got this, it used to be National Coalition for Cancer Survivorship. That was the name of it, but now it's canceradvocacy.org. It's on my on Blackboard in my websites. So at this, but that rehabilitation stuff, what I just said, client regains strength, recovers from surgery, all of those things, I want you to study that, look at that. These other ones are FYIs, so it's interesting, but you don't have to memorize this or anything. So the psychological rehabilitation, you can have quality of life issues, of course, and they call it the 3 seasons of cancer survival. And you have diagnosis, and then extended survival and permanent survival. And those are just some terms. Don't really worry about that. It's just some of the things that can be used to set goals when people do have emotional or psychosocial issues. And let's see here. Again, I've got that they do have self-help groups available for survivors. The canceradvocacy.org, National Coalition for Cancer Survivorship. They are a lobbying group. They lobby to Congress and stuff for rights of cancer patients. So anyway, that National Coalition for Cancer Survivorship they are really important in helping cancer patients or for the government to deal with it. And so that can be maybe one of our healthcare issues. But we're going to have our basic skills of communicating and finding information and making decisions and solving problems and negotiating and standing up for your rights. And that's for the patients to do. That's what the cancer advocacy survivorship group expects of their members. And so it does have special topics about them for the newly diagnosed and for older persons, and how to pay for care, how to care for the caregiver, how to live beyond cancer, and the final stages of survivorship. Those are some examples of things that you could look up if you need that, or if one of your patients needs that. So again, you don't have to memorize that part, but do really study the part with that rehabilitation, this first couple of sentences there on the notes page. And then here on the cancer specific information available on the website, the mission of the cancer advocacy group is to advocate for quality cancer care for all people touched by cancer. And the vision is the advocacy organization reflects the needs of all cancer survivors to affect policy change at the national level. And that's the lobbying issues. And then the rest of the stuff, again, it's really just FYI stuff, but the mission and the vision, look through that as well. So that's the major part of our rehab thing. So let's see what time we've got now. So let's come back at let me see, let me get here. I'm going to pause the recording here, and we'll come back at 12:30 and work on our children's cancer PowerPoint, and hope we'll get through. It's not very long, and I'll see you in a little bit. And I was going through my chat. Okay, let me get the recording going again now. Okay. All right, so this is our cancer in children and adolescents, and there's not anything on the notes page for this one. This is the cancer trends and death rates in children, cancer incidence trends, and the incidence is if you can see, is going up, and then mortality is going down though. So that's pretty cool. But you know, we don't like this incidence business either. But so these are the age adjusted to the 2000 standard population, and incidence rates are presented through 2016 and adjusted to account for delays in reporting. So because sometimes it comes after the fact, and that's why it's sort of lagging. And this slide came from early 2020. So anyway, the among the children and the adolescents combined ages 0 to 19, the brain cancer has surpassed leukemia as the leading cause of cancer death. And although treatment options have improved for both cancers, the therapeutic advances have been particularly dramatic though. So the death rate in this age group declined by about 70% for leukemia, compared with 30% for the tumors of the brain and the other nervous systems. So this is we can have another one because y'all haven't really studied that part yet. But this is just showing that yes, we do have incidents in children and adolescents, all the way the combination of like 0 to 0 to 14, and then 14 and 19, they're going to separate that. So here's our adolescents and the children 0 to 14, and adolescents of 15 to 19. Sorry about that. And then all the sites, including benign brain, because they are including benign brain tumors because they treat it the same way as they do malignant. So we have our 15 to 19 year olds, the incidence rates are greater, and then our 0 to 14 years old, you're seeing that it's less. So, and then our leukemia and our brain, this is the incidence, like the number of of kids. And so so the blue is the 0 to 14. So we have more leukemia cases in the 0 to 14 year category, and it's only it's less in the 15 to 19 year group. And then the second one is brain and central nervous system. The 15 to 19 year olds have more cases of the brain and central nervous system, but the 0 to 14 have a little fewer than that. So I do want y'all to, like we did for the adults, this is the incidence rate among children 0 to 14. It's the top incidence for them is the leukemia, and then the second is the brain and central nervous system, and then it's just flipped with the 15 to 19 year olds, the brain and central nervous system. And then the leukemia. So, and then we're going to, you need to know the top two in the incidence. So 0 to 14 is leukemia, and then brain and central nervous system, and then the adolescence is 15 to 19, which is the brain and central nervous system, and then leukemia. So then you go hear about the top 3 causes of cancer deaths. Don't worry about the third one. We're just going to do 2. And so the brain, this is children to 0 and 14. So there's more children that are dying from the brain and the other nervous system disorders or the cancers. So it's just flipping. So the 0 to 14 have more deaths from the brain and the central nervous system, and then the leukemia, they have more incidence of leukemia, but they don't have as many deaths as they do for the brain. So then it's flipped this way. There's more leukemia deaths for the adolescents than there are for the brain and central nervous system. So it just flips. It sort of flips like it does for the adults. So I do want you to understand that, because they are separating it, because the adolescents mimic a little more so than the they go more like with the adult statistics than the children 0 to 14. So that's, I do want you to do like, okay, incidence for 0 to 14 year olds, leukemia and brain and other nervous system. And then for the death rates, it's brain and then leukemia. And then with your adolescents, you're going to do brain and central nervous system incidence, and then leukemia. And then the death rates would be leukemia and then brain. So it just flips. So it's gonna, if you know the first one, then you'll know the second one, because you know it just flips the other way. So this is just going to be, these are statistical kind of things. The 5-year survival rates percentage in children and adolescents by age up to 2015. This is one of those lagging behind things too. But see, they published this in 2019, and so this is the age at diagnosis and leukemia and all that kind of stuff. But this is not something that you have to worry about on that, though, the relative survival rates. But it's I think that chart is easier to work with than this, those big blue and red lines and such. So, but this is the survival thing, the 15 to 19 year olds. This is just survival rates, period. It's not telling you whether it's leukemia or central nervous system or whatever. So just that's just something to look at. Don't worry about that one. Just look at the chart. All right, so our incidence of childhood cancers, the leading cause of the disease-related death in kids younger than 15 years. So do look at this, that it is cancer, childhood cancer is the leading cause of disease related death in kids younger than 15 years old, because that's not the greatest cause of death in children, because it's usually accidents. It's so that's another thing. So it is disease related death, leading cause of disease related death. Emphasize that and mark that on, or highlight that on your notes page. And our mortality rates continue to improve. We saw that on our chart. And then our overall survival is now 84%, but it does depend on the age and the type of cancer. And then the primary tumor site varies by age. And do look at this yellow here. All children and adolescents with cancer need care coordination by a pediatric oncologist. So it is a devastating psychosocial issue for families, and they're in a state of crisis and shock, and nuclear and extended families need to be included in the plan of care. So that with the child's reaction, with our developmental, infants and toddlers are unaware of the severity. They got to deal with the issues with pain and separation from home and family and anxiety of caregivers, and they don't know why all of this is happening to them. But then when you go to preschoolers, they begin to understand more, and they might believe that they caused an illness by bad behavior, and they may wonder why parents can't or won't make it go away. And then school age, they can understand that they've got a disease, they've got problems, and that they can talk about their experiences. And then adolescents do find their peer contact is reassuring and supportive, and they'll talk more to their peers usually than they would with adults. And again, people are individuals, but in general, that's what happens. And pediatric cancer patients might be hospitalized after the diagnosis, but they might be managed in the long term with outpatient treatments. And either way, the family's dealing with a life-threatening illness. So the research is inconclusive as to whether there are increased rates of depression than other children that don't have cancer, and anxiety can be interpreted as depression. And some of the antidepressant medications can treat anxiety too. But you assess the family dynamics and their communication skills, and compare their child's baseline mood to how they are after the treatment interventions start to be initiated. Okay, so our etiology of childhood cancer, that can be multifactorial, but there can be external stimuli that cause genetic mutations like carcinogens, and the immune system and the gene abnormalities, the failed immune surveillance, and viruses that change proto-oncogenes to oncogenes in absence of tumor suppressor genes. And there can be chromosomal abnormalities that they're born with, or their chromosomes can be damaged, and the genes can be damaged because of environmental factors too. The rate of the cell growth in children is a factor, and the continued presence of the fetal cells that you can note. And the children's cancers are more often embryonic during the development of the fetus, or genetic, and it's only rarely related to lifestyle or environment. So some chromosomal abnormalities are linked to the increased cancer risk, and especially notice the Down syndrome. I do have those other two, Wilms tumor and retinoblastoma. You don't have to worry about that, but do remember this one. The Down syndrome is related to leukemia. For some reason that trisomy 21, that's the 21st chromosome. It's messed up. It's not right from birth, and so there, for some reason, there's more of a chance for Down syndrome children and adults to eventually have a case of leukemia then, and it's like 20 to 30% higher incidence than normal children. So then many cells in the children do divide rapidly, and including any cancer cells that can be present. And the programmed cell death, that apoptosis we talked about, it might not be well developed in some young children. So that can be a problem also. So our external stimuli that can cause genetic mutations, the carcinogens like diethylstilbestrol. I don't know that they use that so much anymore, but it is a hormonal agent that used to be given to pregnant women and to help to make them feel better in their during their pregnancy, I guess. And so, but that can cause like vaginal cancers in female children, and eventually, and then steroids, chemotherapy agents, immunosuppressants, radiation exposure, especially in leukemia and thyroid cancers that they're having radiation treatments, and then ultraviolet radiation from the sun. It can cause skin cancer, and the secondary cancers can happen when the treatment for a primary cancer involves high doses of radiation or certain types of chemotherapy. There can be a secondary illness then, or secondary cancer. An immune system and gene abnormalities. The immune surveillance is not as good because they're in children. And it's because they're kind of like about 6 years old is when they're kind of at their sort of maximum of developing the immune surveillance, and the diseases that can affect the immune system, and viruses and familial genetic abnormalities. So in that first month of life, the decreased phagocytic immune function, it's also in preemies and small for gestational age infants, and decreased specific immune function. Infants have a lower antibody level than adults do, and they're more vulnerable to the bacteria and viruses. And AIDS or immunosuppressant drugs can increase the risk of lymphomas and sarcomas in children. And viruses can alter the immune system or alter the genes that normally regulate cellular growth. And one of those is Burkitt's lymphoma. And it's more common in, oh gosh, I can't remember where in Africa, but there are some sort of kind of pockets of that with the Burkitt's lymphoma, and it happened from a certain type of virus. And then cancers resulting from inherited gene abnormalities, and it involves every cell and are usually aggressive. So retinoblastoma and Wilms tumor are some of those chromosomal issues or gene issues. Okay, so the symptoms of childhood cancer, we could have cachexia, pain, anemia, infection, bruising, petechiae, neurologic symptoms, or palpable masses. And pain can be direct or indirect. It could be because of nerve receptors, obstruction, inflammation, tissue damage, stretching of organs, and invasion of the tissues, and anorexia and weight loss and anemia and weakness. They call it asthenia. If you see that word asthenia, that means weakness. Feeling full quickly, that early satiety, and that kind of concentration camp look, the cachexia. The chronic bleeding or iron deficiency and inefficient absorption or use of the iron, altered or immature immune systems, and bone marrow cancers inhibiting the maturation of those immune cells, and use of steroids, decreased platelets, and impingement on the brain or the nervous system, like that increase, that ICP. It is intracranial pressure, and where it has the decrease arrow is level of consciousness, and then eye abnormalities and behavior or physical function changes, and masses that are commonly in the abdomen and chest and neck and other sites. So the treatment modalities and the nursing management for childhood cancers depend on the site of the tumor and the stage of the disease. And you ought to look in your maternal child health book about the teaching highlights, and I've got some page numbers on there. Hopefully you can find that. And then that goals can be curative or supportive or palliative. And then our treatment options for childhood cancers, surgery and chemotherapy and biotherapy and radiation therapy and bone marrow and stem cell transplantation. And so at this particular point, this says no about ANC count, but you don't have to know about it now because we already just talked about that, and we are going to emphasize that in 211. So don't worry about that. It's just that the ANC is just an issue. And if that absolute neutrophil count is too low, then you're not going to be able to administer the chemotherapy, and that might delay treatment, or maybe the progression would move ahead while you're stopping the treatment for a while. So that's just an important issue. All right, so oncologic emergencies in children from the maternal child health book and the concept book in the intro section. Y'all don't have the concept book, so don't worry about that. Study the nutrition in the child with cancer, and oral care and reportable events and pain management and psychosocial support and cancer and stress and cancer and sleep and fatigue. Okay, so the methods for decreasing cancer incidence in children: that increase fruits and vegetables, at least 5 servings a day, and use of sunscreen, at least 30 SPF, discourage smoking and avoid secondhand smoke, and teach about screening tests for early detection, and vaccinate against the HPV. I think we've addressed that about 3 times now, haven't we? But and then decreasing incidence of cancer in children, also in the 4th or the 5th edition, whichever one y'all have. I have some pages on there. So some survivorship issues in childhood cancers. You can have late effects or after effects from surgery or radiation or chemotherapy. And then the American Cancer Society website, you can search for childhood cancers if you want to look at that. But what causes the late effects? It can be chemotherapy or radiation, major surgery, but it can be caused by cancer that damages the healthy cells, or the cancer treatment that affects healthy cells in the body, and the cancer treatments like surgery or radiation therapy or chemotherapy or bone marrow transplant. They kill cells that grow quickly, such as cancer cells, but in a child, there are healthy cells in the bone and the brain and other organs that are growing fast too. And so the treatment can damage those cells and keep them from growing and developing the way they should. And healthy cells that aren't fed the way that they should be, there's ongoing cell injury and death of healthy cells, and scar tissue formation might be causes of late effects. And again, in your maternal child care or child health book, the impact of cancer survival. And so you might want to look over that. And then adult survival. Let me see if I get that right. Yeah. So our adult survivors of childhood cancer need support for the rest of their lives. And researchers have found that some survivors of childhood cancers of the CNS may battle lifelong cognitive deficits, including like poor memory and disorganization and low IQ and inadequate emotional control. Okay. And then let's see, look at this other one. Okay, so our I've got my thing out of order or something. Wait a second. Make sure I got it. Okay, so poor memory and disorganization and low IQ and inadequate emotional control can be a big issue. So there's a childhood cancer survivors study. It's a component of a long-term follow-up study that started in 1994, and it's collaborative and multi-institutional, and it's funded by the National Cancer Institute. It's composed of individuals that survived 5 or more years after diagnosis of cancer and leukemia and tumors or similar illness diagnosed during the childhood or adolescence. And all of the participants in the long-term follow-up study have a confirmed diagnosis of cancer, and it's retrospectively listed for the diagnosed between 1970 and 1999. And there are over 5,000 siblings of survivors that that serve as a comparison group for the study. And so they went through United States and Canada. It's coordinated through St. Jude Children's Research Hospital in Memphis, Tennessee, and the Statistical Center and Fred Hutchinson Cancer Research Center in Seattle. And Columbus, Ohio Biopathology Center and Biorepository and Molecular Center in Cincinnati, and Radiation Physics Center at MD Anderson in Houston. And so this was directly from the St. Jude website that they're doing lots of research about what happens to children after they have taken all of these treatments. Okay, so our childhood cancer survivor study, it started in 2006. It was reported in 2006. And there's 62% of adult survivors of childhood cancer, and they had at least one chronic condition. And 27.5% had a condition that was severe or life-threatening, like osteoporosis, scoliosis, heart disease, stunted growth, premature menopause, chronic pain, infertility, hypothyroidism, and second cancer. So that's really pretty scary. But I did get this updated with the cancer.gov with the types of childhood cancers and everything, and it was updated from the current. It's current as of fall in 2019, and so there are lots and lots of potentials that can happen. Body parts and organs can be involved, and body image issues with amputations and scarring and radiation late effects depending on the body area that's radiated. Secondary cancers can come up. Chemotherapy can cause short-term side effects and late effects like cardiac and pulmonary and neurologic and learning disabilities and reproductive stress. And about insurance coverage and employment and depression and fear that it's going to come back. Encourage the hopefulness and purpose in life, and fundraising for cancer research, those kinds of things. Some of the adults that survive childhood cancers are helping to fundraise for cancer research. So they encourage the children with cancer to accomplish educational goals to help with that adaptation, to let that be their goals and not be try to interrupt the anxiety and worry. So the Institute of Medicine report on the childhood cancer survivorship, I know this is not really that interesting necessarily, but it if you really think about it, it's not over once they have mastered the cure of like a leukemia or whatever. That there's some other things that can occur in the rest of their life. So it really is important, and survivorship is a huge deal in all kinds of journals and everything anytime you look at them. So recommendations for the pediatric oncology care team is that you change the focus from treating cancer to promoting lifelong wellness. So that's a big deal. You're not going to just be treating the cancer. You're going to promote lifelong wellness, and you need to start that. Whoever is working with those children in the healthcare field, they're going to be looking at their whole life. We want to make their whole life a quality life. And then repeatedly discuss the importance of long-term follow-up care with the family, beginning at the diagnosis. We start making plans for the rest of their life. Beginning at diagnosis. So the childhood cancer survivors often don't have follow-up care, and it's relatively new now, since before 1970, that nearly all patients died within 5 years, and today over 80% survive to adulthood. And in 2006, that Institute of Medicine issued a report recommending that every cancer patient receive an individualized survivorship care plan that includes guidelines for monitoring and maintaining health. And in response to that report, many groups have now developed various types of care plans to help improve the quality of care of survivors. And that's through cancer.org. That's American Cancer Society. And so you can search for survivorship care plans in there. And
There usually is long-term care, including annual exams in children's cancer centers, support groups and screening for late effects. But after age 21, then that's kind of like you're just kind of getting chopped off because you're not pediatric anymore, and you can be lost to follow-up. So primary care physicians may not receive a full history from the client unless the pediatric oncology team coordinates this transition from the pediatric care to adult care. So in 2007, and this was the most recent update on this, the Children's Oncology Group, that's one of my websites that I've got that listed on Blackboard. It says it's just children'soncologygroup.org, and they published a guide for follow-up care, and it's available at survivorshipguidelines.org, but you can also find it through Children's Oncology Group also. But primary care practices can find information on every facet of survivor care, and patients and parents can also receive information on those late effects. So this is really important. This is still going on. And I know it looks like, oh, well, this is old stuff. No, it's not. They just had the Medicine Institute of Medicine report in 2003, and then we've got that Children's Oncology Group that's following up with this, and they really do strive to let patients know that they definitely need it. Like when they reach 21, they need to have a transitional I guess communication with their healthcare provider if they're not going back to the pediatric visits and all, and so it just sort of goes by the wayside. And this is what's really important. It's important that you communicate with the physician. Like if a pediatric oncologist will communicate with their pediatrician, and then once they are out of pediatrics, then they want to talk to the patient and say can we get you transferred over to somebody that we can get your records to, or we'll give you your records and you can take it to your healthcare provider. So it's very, very important, because there are definitely potentials for problems with or side effects from the treatments that those folks have gotten. So anyway, that's a very important part of this, that survivors have communication with the follow-up doctors for the rest of their life. So, okay, let me get off of here and see if anybody needs anything for all of this. Let's see. Let's see what we got. This thing about the rehabilitation, it's really that very first part where it says where the stuff that's underlined, that's really the major part. On the very last one, for our cancer PowerPoint, the very last PowerPoint, it says rehabilitation exemplar involving the client regaining strength and all that, and all that stuff was underlined. And it does say it may involve PT, OT, whatever. That little paragraph is really the very most important part. And then at the cancer specific information. Yes.
Please, can I ask, where are you at? Your last name.
Well, let's see. This is I had somebody else on a chat, and I was answering a chat.
Okay.
So anyway, and so that rehabilitation, and it's on the very last page of the cellular regulation part. and it has that rehabilitation. The first paragraph of that is, then it stops with saying direct nursing care and teaching. The rest of that stuff is FYI stuff. And then when it says cancer specific information available on website, this is that cancer advocacy group. And so I just want you to look at the mission and vision. That's part of survivorship and rehabilitation too. They're promoting that. So that's really what on that particular notes page is all that you really need to study on that. Okay, I hope that will
I
get.
don't have the cancer. I don't have the survivorship PowerPoint. I don't have that as the last slide.
Well, so your last slide doesn't say evaluation.
It does, yes, ma'am.
And it's on the notes page.
Oh, okay, thank you.
Yeah, the notes page starts with that rehabilitation thing, and then at the a little beyond the middle, it'll say mission and vision for that survivorship group. And so that's really all that I wanted you to get to. Does that make sense?
Yes, ma'am. Thank you.
Some of that is FYI, because it's interesting, somewhat interesting, but the exemplar part with the survivorship and rehabilitation part, and that it's very important. So yeah, they're just those little spots. The rest of it's FYI. Okay, let's see. Okay, so Becca's still with us.
Yeah, she's listening in with me, Miss.
Oh, good. Okay. So did y'all have other questions? Well, anyway. Yeah, some people were wondering about a blueprint, and I don't know if Miss Walker will do a blueprint. What we usually do for finals what I do anyway is like list how many questions that each unit has, but I don't have that yet because we're multiple people are doing the questions, and I think only 3 of us had finished, and that hopefully they're finished now, but I'm not really sure. So Ms. Walker might know about that. But anyway, I'll check on that a little later on, because that's for the final is for Friday, and then my test is for mine, and Miss McCoy's is for tomorrow. So I need to get y'all on another Zoom. I was afraid since we already had a Zoom, and I was going to put another Zoom, and it was like, okay, I need to get this one done, and then I'll set it up, because it can get confusing as to which one you want to click on. So, but
Miss Beaver.
Anyway.
Miss Beaver.
Yes.
Yeah, I want to clarify something. So, in the PowerPoint about cancer in kids and adolescents, so you just want us to know, the rate, the ones you put in red, that's all you want us to know for the exam?
So which red now?
The things that are on red, like the first page, like the incidence rate, and
in the mortality. That one's not, you're not going to really have a specific question about that. It really is just something that's a knowledge context of it. So we do know that the incidence is rising, but the mortality is lowering. It's not lowering fast, but it is lowering, and so that's a good thing. But then it's not the best thing that we're having more incidents of it too, though. So but that's not necessarily something you need to know for a test question. It's really sort of a setting of a context. But do just remember that with the the 0 to 14, it's the number of cases is greater for leukemia, and then the second is the brain and other nervous system problems, and then with the adolescents, it's the other way around, the brain and other nervous system problems, and then the second is leukemia. And then when you look at the causes of death, though, for 0 to 14 and 15 to 19, is just the opposite. The 15 to 19-year-olds have more deaths from leukemia, and then the second is the brain and other nervous system, and then it's the brain and other nervous system is what the 0 to 14 die from, and then the second one is the leukemia. So it just flips, sort of like it does with the prostate and the prostate and breast, and then the lung with the adult statistics. So I hope that will help, because sometimes it's very confusing, I think, on that one where it's a 5-year relative survival rates and all that stuff. But it's, yeah, the 3 top causes of cancer death is it just flips. It's not much difference, actually. It's 0.7 and 0.6 on both of them. So they're really close. So did you get that?
So you said we needed that it's a general knowledge, right?
Well, I do want you to know that, like you did it, like we do it with the adults, with the breast cancer and lung cancer and colon cancer. And then, yeah, so if you do leukemia, brain leukemia for the younger ones and the older ones, and then with the deaths, it's brain leukemia and leukemia brain. So it just flips.
Okay, thank you.
All righty. All right, is everybody set? Go ahead and turn the recording off. But in case somebody had a question, I guess we can head on out, huh? I'll talk to Ms. Walker about something in a minute. Well, I'm gonna go ahead and end it up for us.
Thank